The topic is hyperkalemia. So I'll start with a case discussion. Like Dr. Jose just mentioned about a patient in the ward having coconut water engine collapsing. This is something that we see almost every day. Patients coming to the dialysis unit. This is a 65-year-old gentleman, a diabetic for more than 20 years, hypertensive for more than 10 years. He has coronary artery disease. An angiogram was done 3 years ago and it was found to have a single vessel disease, and he was advised only medical management. It was not very significant, requiring angioplasty. Around the same time, he was detected to have chronic kidney disease, and on conservative management for 3 years, gradually progressed, reached end-stage renal disease, and has been on maintenance hemodialysis for the last 2 months. He is advised to do thrice a week dialysis, being a diabetic, having coronary artery disease, etc. But he does only twice a week, the usual problem that we face. I think, the host, can you mute everyone, please? A lot of disturbance. Elias, so somebody, can you just mute the crowd because there's a lot of disturbance. Now the patient has been advised thrice a week dialysis, but he's doing it only twice a week because he feels that he's okay and his urine output is good. These are the medications he's taking. Patient is on amlodipine, telmisartan, clonidine for his hypertension. He's on gliclazide as well as insulin for his diabetes. For his heart, he's on ecosprin, clopidogrel, and statins. And he's on getting calcium supplements and vitamin D, and iron and erythropoietin. Again, he was advised to take it twice a week, but he's taking it only once in a week. The investigations which was done 2 weeks ago when he had come for his routine dialysis showed he was still anemic. Probably he did not take his diabetic medication, so his sugars are high. He's underdialyzed. He's doing only twice a week, and his creatinine is nearly 15. His potassium is high, phosphorus is high. He's malnourished, and he's not adequately dialyzed. But still, he insists on twice a week dialysis on Mondays and Thursdays. So last Sunday around 11 p.m. he comes to emergency room. Last dialysis was on Thursday. He comes at 11 p.m. to emergency room with severe dyspnea, chest comfort, giddiness since 2 p.m. And he thought he'll be okay. So waited, and at 11 o'clock in the night, he suddenly decided that he's not okay. And he comes to the casualty. There he looks sick, he's restless, dyspneic, tachypneic. His heart rate is on the lower side. BP is on the lower side. He has edema. Sugars are okay. Because he's hyperventilating, his saturation is also okay. But his ECG, because that's the first thing they do in casualty, the ECG was done, and the ECG shows a wide QRS complex, and there is changes in the Q wave as well as ST segment elevation. I'll show you the picture. So there is ST segment changes in the leads 2, 3, and all, and the reciprocal changes in the 1 and AVL. So a coronary artery disease patient with ECG changes, the first thing they call is cardiology consultation. And the patient, while in the casualty, starts developing further bradycardia, BP starts to fall, and so emergency is shifted to cath lab and a pacemaker is inserted. They did a shot of angio, they did not find anything significant, so they did not do a plasty or anything. They did the pacemaker. Once the temporary pacemaker was done, his BP stabilized, heart rate stabilized, and the patient started feeling better. That's when the reports came. The reports showing hemoglobin of 8, urea is very high, creatinine is nearly 20, and he has severe hyperkalemia. So that was the problem. The patient was taken for emergency dialysis in the cardiac care unit itself. Dialysis was uneventful, and post-dialysis his potassium came down, and he was counseled again regarding the need for appropriate adequate dialysis, diet and drug modification, which we'll discuss a bit later. So this is a typical case which you and I see almost every other day. So coming to this, patients with end-stage renal failure, to live, they need to be either transplanted, which is not very common because of various reasons, which I'm not going to it. The second best option is dialysis, either CAPD or intermittent hemodialysis. This is to maintain the fluid and other electrolytes within normal limit, especially potassium. Most of the deaths that occur in dialysis is due to sudden cardiac death. And often we just say cardiopulmonary arrest and leave it. But what is the exact cause? Very often we don't know, or we don't even look for it. And even for other patients who are not on dialysis, in general, patients with chronic kidney disease, nearly 25% of the deaths are sudden cardiac deaths, most probably an acute myocardial infarction or an arrhythmia. And this patient population with end-stage renal disease, they already have some structural cardiac changes like hypertrophy of the left ventricle because of long-standing hypertension, or they have ischemic heart disease, or they might even have both. And very important is when we dialyze them, especially a patient whose potassium is on the borderline higher side, rapid changes or large changes in the serum potassium level can cause cardiac problems. Potassium of 6, which is suddenly brought down to 2, patient can have problems. They can have arrhythmias and again have a cardiac arrest. So potassium is the third most abundant mineral in the body. Calcium and phosphorus are the other two. It helps the body to regulate fluids, very important in sending nerve signals and regulating muscle contraction. This is the main job of potassium. And almost all, 98% of the potassium is found within the cell. And of this, most of it is found within the muscle cell. So our body, as you know, is made up of water. 60% of the body is water. And it is in two compartments. The intracellular compartments, 2/3 of it is found within the cell. And the remaining 1/3 is found outside the cell, the extracellular compartment. This comprises the blood, the plasma, the spinal fluid, the interstitial fluid, the peritoneal cavity, the little bit of fluid which is there in the peritoneal cavity, pleural cavity, but it's mainly the interstitial fluid and the plasma which contributes to the extracellular fluid. And the water balance between the intra and extracellular fluid is affected by the electrolytes, mainly sodium and potassium. So if you see in this figure, you have intracellular fluid, which is about 2/3 of the body, the water, and the extracellular fluid, which is predominantly interstitial fluid and plasma. The same thing here, mainly intracellular fluid, the total body fluid, and the extracellular is divided into interstitial fluid and plasma. Now, if you look at this picture, you see the intracellular fluid, it's predominantly potassium rich. Sodium is a very small amount. What we measure in the blood is the extracellular fluid. The potassium here is low and the sodium is very high. So the total body sodium and potassium level will be almost the same. But most of the potassium is within the cell and most of the sodium is outside the cell, in the interstitial as well as in the plasma, in the extracellular fluid. So it is very important to know that. If the potassium level in the extracellular fluid increases, that is when the trouble occurs. So this is the picture. Inside the cell, it is mainly potassium. Outside the cell, it is mainly sodium and other electrolytes. And how is this maintained? This is maintained by a very important pump called the sodium potassium pump, and it is controlled by the sodium potassium ATPase. This energy driving pump pushes the sodium outside of the cell and pushes the potassium into the cell. So this pump maintains the level of potassium high inside the cell and maintains the level of potassium low outside the cell. If this pump is not working, the potassium will leak and go outside the cell and it will cause damage. So this pump, the sodium potassium ATPase, is very important to maintain the potassium inside the cell and the sodium outside the cell. So the intracellular fluid has a low concentration of sodium, high concentration of potassium. The extracellular fluid has a high concentration of sodium and a low concentration of potassium. Now, as I mentioned, potassium is the main electrolyte in the intracellular fluid and it determines the amount of water inside the cell. Similarly, sodium is the main electrolyte in the extracellular fluid and it determines the amount of water outside the cell. And the number of electrolytes relative to the amount of fluid is called osmolality. You would have heard the term osmolality. So the osmolality inside and outside the cell is usually the same. And there's a balance of the electrolytes inside and outside. Sodium outside, potassium inside. If there is any shift of this, then the osmolality will change. And potassium is very important for the nervous system. The nervous system, as we know, relays messages between the brain and the body. And this is sent by waveforms, the nerve impulses. These impulses help to regulate the muscle contraction, the heartbeat, the reflexes, and a lot of other body functions. So every function of the body is controlled by the brain, and the message from the brain is sent to the different parts by the form of nerve impulses. And this nerve impulse is generated by the movement of sodium and potassium. When sodium moves into the cell and potassium moves outside, the nerve, there's an imbalance, the nerve impulse is formed. Immediately the sodium potassium ATPase come into play and pushes it back to the normal level. So this is the importance of the role of potassium. And this nervous system is helping to regulate the muscle contraction. So if the potassium level is altered, whether it is too high or too low, it can affect the nerve signal and the muscle contraction can become weak. So it is done by altering the voltage of the nerve cell. So high level or a low level of potassium can cause abnormalities in the muscle contraction. And same thing happens for the heart. Potassium is very important for the healthy heart also. And the movement of potassium in and out of the cell helps to maintain a regular heartbeat. But when the potassium level becomes too high, the heart can become very dilated and flaccid and weak, and it cannot pump. The contraction is very weak, and the pumping pressure is very low, and also the heart rate can get altered. It is not enough able to pump the blood to the brain and to the other vital organs, and the irregular heartbeat, which we call arrhythmia, can sometimes be fatal, and it is one of the causes of sudden death. So very often the sudden death that occurs to the patient may be the result of arrhythmia. So we should be aware that changes in potassium level can cause all these problems. It can cause problems for the muscle as well as of the heart. But potassium has a lot of benefits. In a healthy person whose kidneys are functioning normally, a high potassium diet is very good. It reduces the blood pressure, it protects against stroke, it prevents osteoporosis, it prevents kidney stone, it reduces water retention. So potassium has a lot of health benefits, and that is why we tell the patient to take a lot of fruits, the healthy person to take a lot of fruits, because fruits contain a large amount of potassium, and it is very beneficial, especially to control the blood pressure and against cardiovascular events. But what is a safe level of potassium in the blood? Now we are going to talk about the extracellular fluid potassium. Potassium inside the cell is safe. When it comes out, it is a thing which is going to cause problem. And what is a safe level? Normal level is 3.5 to 5. You are in the safe zone. If the potassium level increases from 5.1 to 6, you are in the caution zone. You can get into trouble. The body will tolerate it, but you have to be careful. And above 6, you are in the danger zone. Anytime the beating of the heart can get altered, the muscle contraction can get altered, the nerve impulses can get altered, and you can have a sudden cardiac arrest. So if the potassium is more than 6, you are in the danger zone. Now, a little bit of physiology. I'm not going to the details. Basically, what I mentioned is potassium is pushed into the intercellular space by the sodium potassium ATPase, and it is also stimulated by some hormones, the insulin. And extra potassium, which is present in the blood, is filtered by the kidney. Most of it is reabsorbed, and only 10% of the potassium is reaching the distal nephron. Mainly, it is stimulated by the excretion by aldosterone. High potassium diet also will cause potassium to be excreted. So, if the level of potassium is high in the extracellular fluid, the kidneys will remove it. This is normal physiology. A properly functioning kidney will not cause hyperkalemia, because the moment it senses the potassium to be high, it will remove the potassium out of the body. But it is very important. Impaired kidney function can cause dysregulation of potassium, homeostasis, and the risk of hyperkalemia is increased. So this is the important thing, and all our patients have impaired kidney function. So it is very important to monitor the patient's potassium. So this is just the same thing which I had mentioned. There is two balances: the internal balance, which pushes the potassium from the extracellular fluid into intercellular fluid, hormones like insulin, epinephrine, then metabolic alkalosis will push the potassium into the cell, acidosis will push it out of the cell, aldosterone will push it into the muscle cell. So there is a balance going on between the hormones within the body. The external balance is by the kidney. When the total body potassium is high, the kidneys will excrete it. So if there is any abnormality in any of these things, the balance or the potassium level in the blood can get altered. Now we'll come to hyperkalemia, which is the main life-threatening complication of potassium metabolism. The problem with hyperkalemia, the treatment is there is no universally accepted consensus. There are a lot of guidelines, but there is no consensus about how to monitor, what is the exact level threshold for potassium, how do you manage acute and chronic hyperkalemia. A lot of guidelines are there, but there are, as the number of guidelines increase, that means we are more confused. So the most important thing is serum potassium monitoring should be individualized. You cannot have a standard rule for everyone. For one person, 5.5 may be very high. For another person, 6.2 may be an acceptable range. This is important, especially in patients with diabetes, with chronic kidney disease, cardiac failure, or those who had hyperkalemia, and especially those who are receiving drugs which are blocking the renin-angiotensin system, like ACE inhibitors, ARBs, and aldosterone antagonists. This group of patients should have frequent monitoring of their potassium, because it is a very serious condition, can cause life-threatening arrhythmias with a high mortality. And the people who are at high risk are the elderly people, those who are at advanced stage of CKD, diabetics, and those who have heart failure. And if untreated, hyperkalemia can cause, as I mentioned, neuromuscular weakness. There may be muscle fasciculations, there may be paresthesias, reflexes may be altered, weakness may be there, heart rate can become slow, or it can be very fast. You can have ventricular tachycardia, fibrillation. This will lead to sudden cardiac death. And most importantly, most patients are asymptomatic. Even when there is severe hyperkalemia, even if the potassium is more than 7, they may not have any symptoms. So it is very difficult we should not wait for symptoms to occur. If you monitor the patient's serum potassium, find it abnormal, you have to act. And it, as Dr. Jose mentioned, it can cause a very wide range of ECG changes. The problem is it is so non-specific. It can mimic various pathologies. It can mimic a myocardial infarction. Like in our first case, the patient actually, because he had a history of coronary artery disease, he was taken to cath lab straight, thinking that it's an MI. And it can mimic bundle branch blockers. At the same time, hyperkalemia can occur without ECG changes also. So there are patterns. I don't think you should know the details of it. Just for completion's sake, I'm mentioning it. The T waves can be tall and pointed. There can be ventricular tachycardia. There can be sine wave pattern. If this occurs, it is very difficult to save the patient. Bradycardia. All these changes can occur in the ECG. The T waves can be very tall. Then there can be widening of the QRS complex. And if potassium goes much higher, you can have the sine wave, which will progress to asystole, and then it's death. So we have to catch the patient before the ECG changes occur. And again, it is, as I said, it mimics a lot of conditions. Now, if you see the anterior leads in V3, V4, V5, if you don't know the serum potassium, you'll think this patient is having an acute myocardial infarction, is having ST segment changes, and the patient will be taken straight to cath lab. And this is the problem with hyperkalemia. It mimics so many other cardiac conditions. Same thing again here. You can see the V1, V2, V3, V4, all there is ST segment elevation. But actually, this is a case of hyperkalemia and not an acute myocardial infarction. So in patients with hyperkalemia, the risk of mortality, cardiovascular morbidity, and progression of CKD is increased. And it is also important that there is a U-shaped curve between the serum potassium level, because even hypokalemia can cause problems. So when we are correcting potassium, we should make sure that the patient does not go into hypokalemia. See, if you see here, when the potassium level is less than 3.5, again, you get into complications. If the potassium level is more than 5.5, you are in complications. So we should have a range between 3.5 to 5.5, which is a safe range of potassium. Anything above this or anything below this, you can get into trouble. And also, it can vary according to the patient's underlying condition. If a patient with CKD for many years, he might be able to tolerate hyperkalemia better. But if the patient has cardiac failure or if he has underlying heart block, then a slight change in potassium can precipitate arrhythmia. So it is important to know the underlying condition. So it is not an absolute number of the potassium, but the patient's comorbidity also, which contributes to the risk and morbidity of these patients. The rate of increase in potassium also should be considered. A chronic hyperkalemia, which is gradually increasing is more tolerated than an acute hyperkalemia. Just like the case Dr. Jose mentioned, a patient drinking Elanir, suddenly his potassium shoots up and he can have a cardiac arrest. While if the patient's potassium has been around 5.5 to 6 for weeks together, nothing will happen. But if it was 4 and suddenly it jumps up to 6 over a few minutes, he can be in trouble. A rapid increase in potassium is more likely to cause cardiac abnormalities than a slow, steady rise over months. And also, as I mentioned, patients with CKD, they have more compensatory mechanisms. So they'll be able to tolerate a high potassium. So in CKD, it is less life-threatening than a patient with a cardiac problem. Then there is something called pseudo-hyperkalemia. It's a laboratory artifact. Actually, the serum potassium in the blood may not be high, but when you measure it, you get it high. This is because of the abnormality or the mistakes we do while we collect the potassium. When we apply very tight tourniquet or very small bore needles are used, or when there is mechanical trauma, when the pneumatic transport is being done, when the cells, the RBCs break down, the potassium within the cell coming out, and that is being measured as hyperkalemia, while actually in the body, there is no hyperkalemia. Also, certain conditions like thrombocytosis, leukocytosis, hemolysis, hematoma, rhabdomyolysis, tumoritis syndrome, tissue necrosis of any cause, all these things, when there is tissue, when there is cell breakdown, the potassium level can be high. And this can be a transient phenomena also. So we have to know whether it's a pseudo hyperkalemia or a true hyperkalemia. And the risk factors are, coming to our group of patients, CKD, as the GFR decreases, as the chronic kidney disease progresses, when the GFR is less than 30, the risk significantly increases. Acute kidney injury of any cause is a risk for hyperkalemia, especially if the urine output is low, when there is oliguria or anuria. Diabetics, they have a risk because of the type 4 RTA, and they can be at risk of developing developing hyperkalemia. And many of these patients are on angiotensin receptor blockers or ACE inhibitors. They can be at risk for developing hyperkalemia. Same way, decompensative heart failure. These patients will also be on a ACE inhibitor or an ARB. So these are the group of patients who can suddenly develop hyperkalemia. And as I mentioned, when the GFR is less than 30, the risk of hyperkalemia is much, much, much higher. And then lot of fruits, lot of vegetables which are potassium rich, which are very good for a patient with normal kidney function. All these things are good for a healthy kidney person. But when the renal failure is there, or when there is advanced cardiac failure, then we should be careful. Now the classification again is varying. There are no guidelines or no absolute guidelines because of the various thresholds, so mild, moderate, and severe hyperkalemia. But in general, potassium more than 5.5 is accepted as a cutoff for hyperkalemia. But the adverse effects can extend beyond this threshold. Like a patient with 5 potassium, which was baseline was around 3.5, suddenly goes up to 5.2, and he's already on a ACE inhibitor or already has a heart arrhythmia, he can get into trouble. At the same time, a patient whose CKD is stable, his potassium has always been 5.5. If it becomes 6 also, nothing may happen. So the high normal concentration was also very important to rule out. So we have to know what the baseline potassium of this patient has been. And we have to decide when to treat and how to treat depending on the clinical impact the hyperkalemia has, and more importantly, on the rapid fluctuation of the serum potassium. A sudden increase in potassium is an emergency. It has to be treated. If there is ECG changes or muscle weakness or something, it is an emergency. It has to be changes. We should not have just an absolute number and treat the number, because the patient's baseline potassium may be 5.5 and he'll be absolutely stable. If you correct it, he might go into hypokalemia also. So it is the clinical situation as well as the change in the potassium which is more important than the absolute number. So acute hyperkalemia is described when the potassium concentration exceeds the upper limit of normal. And we know that it's not been chronic because we know the patient's previous potassium reports. It depends on the severity of the increase, the rapid change in the increase, ECG changes, and muscle weakness. So if these things are there, the patient needs to be treated. And what are the aims of treatment? To prevent the cardiac arrhythmias. The cause of death in these patients is arrhythmia, so we have to prevent it. And for that, then we have to control the potassium. So first we give calcium gluconate to prevent the arrhythmia, and then we have the drugs which will correct the hyperkalemia. I'll come into it a bit more detail. While chronic hyperkalemia, the patient, you know that this patient is having a baseline elevated potassium, and in between the potassium level is going up and is already on treatment for the same. Again, there is no consensus on how frequently we have to test or how severity, etc. But many of the treatment includes diuretics, loop diuretics, which will get the potassium out of the body, modify the dose of the renin-angiotensin blockers, remove other drugs which will cause hyperkalemia, and very importantly, diet modification. Tell them to avoid high potassium diets. So, same thing which I had mentioned earlier. The clinical manifestations are for acute hyperkalemia, muscles will be hyperactive or there will be paresthesia, followed by weakness, arrhythmias of the heart, and finally, the patient can have cardiac arrest. And ECG, it will progress to tall thin T waves, followed by prolongation of the PR interval, QRS complex widening, and then the sine wave pattern will happen. When this happens, it's almost the end of the story. And then we have these drugs. We have calcium gluconate. It will not correct the hyperkalemia. It is just to stabilize the cardiac membrane. It's got a very rapid onset of action. It's a short duration of action, but that is enough so that we have time to correct the hyperkalemia. So calcium gluconate is given slowly to buy time to prevent the complication. Meanwhile, we give other drugs to correct the hyperkalemia. One is insulin glucose. It pushes the potassium into the cell. From the extracellular fluid, it pushes the potassium into the intracellular space. Same way, beta stimulants like salbutamol, it pushes the potassium from the extracellular space into the intracellular space. And sodium bicarbonate does the same thing if there is associated metabolic acidosis only. If there is no acidosis, sodium bicarbonate has no role. Then we have drugs which will remove the potassium out of the body, especially the loop diuretics. This will get the potassium out of the body and the total body potassium will come down. Same way as sodium or calcium polystyrene sulfonate. These are used to get the potassium out of the body, and this is permanent. The previous ones, the insulin glucose, beta stimulants, and sodium bicarbonate is only temporary, just shifting the potassium from the ECF to the intracellular space. While diuretics and sodium polystyrene or calcium polystyrene sulfonate will get the potassium out of the body. So, what all do we do if there is acute hyperkalemia? We do the rapidly acting drugs so that we have enough time for it to act. The role is to prevent the cardiac arrhythmia, push the potassium into the intracellular space, and then try and remove the potassium as far as possible out of the body so that the normal electrophysiology of the cell membranes is maintained. So calcium gluconate to stabilize the membrane, inhaled or nebulized beta-2 agonists like salbutamol, and then insulin and glucose which stimulates the potassium to the intracellular space. Then we have the other things like sodium bicarbonate, diuretics. Dialysis is also very important. It will remove the potassium out of the body. And this is for acute management. In chronic management, all these things do not work. We have to use the loop diuretics and dialysis. Now, calcium gluconate is administered slowly. It is indicated to the doses, it is appropriate when the ECG starts coming back to normal, but it is short acting. It will last only around 30 to 60 minutes. And if it is the potassium is not corrected by then, you have to repeat the doses. It does not significantly change the potassium level. The beta-2 stimulants like salbutamol, it pushes the potassium into the intercellular space. It takes about 30 minutes to act. That is why we are giving the calcium gluconate initially. It lasts for 2 to 4 hours. So by the end of this time, it does not, if you don't get rid of the potassium out of the body, again the hyperkalemia will recover. So it does not affect the total body potassium. It only pushes it from one compartment to the other compartment. The same thing with insulin and glucose. We give around 10 units of regular insulin along with glucose, again pushing the potassium into the cell. But we have to be careful because hypoglycemia can occur in spite of giving glucose. The patient can develop hypoglycemia. So we have to monitor the patient's sugar also. Again, lasts for a few hours only. It takes about 30 minutes to act. Sodium bicarbonate, again, it is used only when there is associated metabolic acidosis. Again, it may take some time to act. It is not a rapidly acting drug. It's in the intermediate level. But we have to be careful. We should not overcorrect and cause the patient to develop metabolic alkalosis and fluid overload. Loop diuretics are used to prevent the rise in serum potassium, especially the furosemide, the Lasix that we use. It is also used to control the volume overload in these patients. But if we are not careful, we can cause volume depletion and we can actually worsen the kidney function of these patients. So again, it may not be ideal for long-term use because of the risk of volume depletion and worsening the renal failure. But it is used often, and as long as we can monitor the kidney function and potassium, it is good. Then we have the calcium polystyrene sulfonate. It is used as either as orally or as a suppository, and it traps the potassium in the distal colon, and it avoids sodium retention. Calcium supplement is also occurs because it's calcium polystyrene sulfonate. So this binds with the potassium within the colon and it is excreted out of the body. So it actually removes the total body potassium. Very high doses of calcium polystyrene sulfonate has been shown to cause colonic necrosis, but we are not worried because we don't give that high dose, 90 grams not. We give only around 10 grams to 15 grams. So that is very safe. So calcium polystyrene sulfonate can be given. It does not enter the bloodstream. It is binding with the potassium and it is removed along with the feces. But we should not give it if there is obstruction or if there is hyperkalemia, myeloma, or the potassium is on the lower side. And its efficacy and safety in newborns and pregnant people have not been proven. The thing is, if we give it along with sorbitol, there is a risk of intestinal necrosis. So we have to be careful when all these associate drugs are being given. It can alter the level of these drugs. Then dialysis. Dialysis, either hemodialysis and peritoneal dialysis are the definite options for removing potassium out of the body. Definitely, we should tell the patient to have a low potassium diet. If the patient is on a renin-angiotensin blocker, we have to either reduce the dose or we might even have to stop it. And then a couple of new drugs called paritomar and sodium zirconium cyclosilicate has come into the market. It's not yet available freely, but these are promising drugs which might be used in the long-term treatment of hyperkalemia. So once the patient's acute management is done, then we have to look for long-term, make sure that he doesn't go into recurrent hyperkalemia. So we have to look at the chronic management. We have to look at the underlying causes. Why this acute hyperkalemia occurred? Is it because of his alteration in diet, or did he recently start a new drug? Did he start an ACE inhibitor, or did he drink a lot of tender coconut water or lime juice? And these factors have to be looked for and on an ongoing basis, because you tell them something today, they forget after 2 or 3 days, and again they'll have the same problem. So we have to look at this high potassium diet, renin-angiotensin inhibitors, other drugs. All these things should be looked for and corrected if the problem is there. Diet, we have to reduce the potassium intake and definitely reduce potassium supplements. So this is very important. Again, telling them about fruits, fruit juices, especially orange juice, coconut, all these things, bananas. These are all things a patient, when a person comes to visit a patient in the hospital, these are fruits are the things which they give. Now, apple is a safe fruit. Pear is a safe fruit. Perica is a safe fruit. These are fruits that can be given to these patients because the potassium content is low, but not orange, coconut, or bananas. These things, and very importantly, salt substitutes. Because we tell the patient to take low salt because of hypertension, then they take potassium chloride. And salt substitutes like potassium chloride can actually cause much more harm than reducing the salt intake. So this the problem with these things is fruits is a high fiber content. By reducing the fruits, they can cause constipation, and also it is contraindicating the healthy dietary recommendation to prevent kidney disease, to prevent cardiovascular disease. The DASH diet, the dietary approach to stop hypertension diet. This is where you recommend low potassium and low sodium and high potassium. But in a renal failure patient, advanced renal failure patient, if the potassium is high, we are actually contradicting the diet advice we give. So that is the thing. We should not have a standard diet prescription for any patient. We have to individualize it. We have to monitor his renal status. We have to monitor his electrolyte level and then advise the diet. Because this is a very important trade-off for these patients. Otherwise, if we want to prevent a stroke and give them high potassium, we might actually kill them by causing an arrhythmia. So this is a very important thing. Especially we have to tell the patient, because they might go to a cardiologist and to protect the heart, they might be advising a high potassium diet. So we have to tell our patients, if your potassium is on the higher side, avoid these foods. Then, as I mentioned, stop the drugs or reduce the dose of these drugs which can cause potassium retention. Then the very important thing, which is very relevant to all of us, is the dialysate potassium. Now, this is a modifiable factor that can alter the serum potassium concentration throughout the session. We can adjust the dialysate potassium. We can have a high potassium dialysate, low potassium dialysate, or even a potassium-free dialysate. But if we are not careful, we can actually cause arrhythmias and even cardiac arrest because of the fluctuation of potassium. Now, the question is potassium removed during dialysis? Yes, we know it is removed during dialysis, about 1.2 milliequivalents. For easy calculation, about 1 milliequivalent per kg body weight is removed per session during dialysis. And more importantly, the higher the potassium, the more it is removed because the gradient is much higher. And also, when we are doing dialysis, we are correcting the acidosis. The bicarbonate level, which is high during dialysis, will cause a little bit of potassium to move into the intracellular space. So dialysis will correct potassium in two ways. One, it removes the potassium out of the body. Second is pushes the potassium into the cell by the supplementation of bicarbonate. So we have to be very careful. There is a large fluctuation of potassium which occurs during dialysis. So potassium, which is baseline around 6, if we bring it down to 2, that can also cause arrhythmia. So we have to be careful when we are doing dialysis. Now, a very recent article which came a couple of months ago is a very low dialysis potassium path associated with the low mortality in ESRD patients admitted to the hospital with severe hyperkalemia. This study concluded that a dialysate potassium of 1 is very useful. It decreases the mortality and cardiac arrest in hospitalized ESRD patients. These are patients who are in the ICU, whose potassium as well as the cardiac ECG can be monitored continuously. But I don't think we can extrapolate it to patients who are in the OPD. So a patient, this study, a very important study mentioned by the DOPS, the dialysate potassium, serum potassium, mortality and arrhythmia events in hemodialysis. This study, which was published, we'll just look at it in detail. The study was done because we all know the sudden death is a leading cause of death in patients in hemodialysis. And during the dialysis sessions, the gradient between the serum and dialysate potassium level causes rapid electrolyte shift, and this can contribute to arrhythmias and sudden death. So we don't know. Controversies are there about the optimal electrolyte concentration. In spite of advancing so much in dialysis, still there are controversies. So whether patients' outcome will change if the potassium in the dialysate is 3 or low, 2. This is what they wanted to study. Whether a low potassium or a medium potassium dialysate is going to contribute to this thing was what was studied. It is a prospective study. More than 55,000 patients from 20 countries was studied. So it is a very good study, a large number of patients, multicentric. So there is unlikely to be any bias, and followed up for nearly 1.5 years. And they found there is no significant difference in the outcome, whether the patient's dialysate potassium was either 3 or 2. And irrespective of the serum potassium level, these results were the same. So even if the patient's potassium was very high, we didn't, in the outpatient setting, it was not required to give a very low potassium. Regular potassium concentration is more than enough. Too much of a low potassium can actually cause more problem. So they know that high serum potassium level is associated with outcomes, but a dialysate potassium concentration has only minimal outcome on the serum level. So we don't have to worry too much about the dialysate potassium level. Just because the serum potassium is around 6, we don't have to keep a potassium-free dialysate unless the patient is having ECG changes. So they concluded that rather than altering the dialysate potassium concentration, it is more important to educate the patient on dietary potassium sources, potassium binding medications, potassium elevating medicines, and this is more important rather than modifying the dialysate potassium. So in the inpatient setting, that study showed that a 1 milliequivalent potassium is very useful compared to outpatient setting. But in the outpatient setting, it is something which is totally different, and we'll tell you the difference. In the inpatient setting, the patients are monitored more closely for their cardiac rhythm and hemodynamics. And in the inpatient setting, we can check the potassium, and if we are overcorrecting the potassium, we can correct it. And also this very low potassium level the very low potassium level is only used for 1 or 2 sessions, while the patient is coming for a maintenance dialysis 3 times a week. If we keep this very low potassium, actually we might cause sustained depletion of the potassium source from the intracellular compartment, and we can actually cause hypokalemia and more complications. So that is basically about potassium. In summary, if the potassium level is high, acutely high, you correct it with calcium to stabilize the cardiac membrane. You use salbutamol and insulin dextrose to temporarily push the potassium into the cell, and then you use diuretics or dialysis and potassium binders to remove the potassium out of the body. In the chronic situation, more importantly is dietary counseling, monitoring the drugs, modifying the drugs, adequate diuretic therapy, giving bicarbonate to correct the metabolic acidosis, and consider potassium binders. So in summary, if there is severe hyperkalemia, give calcium gluconate to stabilize the myocardium, give insulin dextrose and beta agonists to shift the potassium into the cell. If there is metabolic acidosis, you can give bicarbonate. Then if the patient's fluid status is okay, then we can give diuretics, give potassium binders, and these are the 2 definite ways how potassium can be removed out of the body: by diuretics, by potassium binders, and by dialysis. In acute hyperkalemia, calcium gluconate, it does not reduce the potassium. It is basically to stabilize the cardiac membrane. You give the insulin glucose and the beta-2 stimulants. It only pushes the potassium into the intracellular space. It does not change the total body potassium. Bicarbonate only if there is metabolic acidosis. Dialysis and the potassium binding resins will increase the elimination of potassium from the body. So in the acute setting, we stabilize the cardiac membrane, use insulin dextrose and beta stimulants, and then meanwhile we get the patient onto dialysis and we use the chronic therapy. And ECG cannot rule out hyperkalemia. It cannot define hyperkalemia also. It can cause multiple changes, very non-specific. But if you suspect the patient has got risk for hyperkalemia, the patient has got CKD, the patient is on an ACE inhibitor, ARB, baseline potassium is high. When you look at the ECG, look for heart rate. Look at the ECG changes, the PR prolongation, the widening of the QRS complex, and look for ST changes, the T wave, which are narrow and tall. And if any of these things are there, you give calcium gluconate because it will stabilize the heart. Meanwhile, you can find the exact cause of it, and then you can treat the patient. Thank you very much.